a couple of the guys waiting. So today we're actually not going to learn any new ultrasound techniques per se. We're actually going to take whatever we've learned so far and put it into something a little bit more practical called the rush protocol. And some of you may be wondering what the hell is the rush protocol. There's nothing to do with how fast you work in A&E. It's actually a rapid ultrasound in shock. All right. So we all know shock is one of the things that we encounter quite often in emergency departments. So I'm going to ask the students, when we talk about shock, what do you all think about? Okay, first of all, if you're thinking about electric shock, go back to medical school. What do you think about when you think about shock? Just anything that comes to your mind. Okay, I hear a lot of, hypotension, tachycardia. Yeah, okay, right. In some ways, you're right. Okay. So basically, shock is decreased perfusion, all right, to your vital organs. That's the easiest way of putting it, all right? So there's various reasons for it. Maybe one of our interns can tell us what are the different types of shock, or even Dr. Masondo, because I know she knows this. She's just looking at you because she's like, these people don't know what they're talking about. Yeah. Very good, hypovolemic shock, right? And not hypoxia per se, no. You don't get hypoxic shock. You get respiratory failure and that's from hypoxia. Septic shock, neurogenic shock, cardiogenic shock, and what we also call obstructive shock, right? Obstructive shock, which we're going to get to. So what we're going to do today, and one of the main signs of shock is hypotension, right? So that's one of the first things that we see. So in other words, we've got a patient who comes in with a low BP. So the question is why? So patients don't come in with low BPs because we can control our heart rates and we can control the beating and contractility of our heart. There must be a reason behind it, all right? So today is going to cover two things. Number one, we're going to remind ourselves of all the different types of shock. And number two, we're going to see how we can use our ultrasound to actually confirm whether it is that type of shock or not, right? So the easiest way to think of shock. Shock depends on the heart and it depends on your blood vessels. So for the remainder of this talk, I want you guys to imagine that your mouth is the heart, the pump, and you've got a straw in your mouth, okay? What you're using, your pump is trying to push through the straw, okay? And that's how we're going to describe each and every shock, all right? And that's the easiest way that I found for people to understand. You can see we're supposed to have this last week, but we didn't, so we'll have it this week. So let's see. So what is it? What is the rush protocol? Rapid ultrasound for shock, all right? So hypovolemic, cardiogenic, distributive. Distributive is the other way of saying septic and neurogenic, which we'll get through now, and obstructive, which is pulmonary embolism, tamponade, and also if you have a patient with hypotension. So basically what you are doing is now you're taking your ultrasound machine and by looking at certain views. So in other words, we're going to be mainly looking at the heart because it's the pump, and we're going to be looking at the pipes, which are the veins, and we'll be looking at the tank, which is the aorta as well. So we're looking at those three aspects, and then we'll kind of see from there what happens. Is there somebody new there? Have you been with us before? Oh, okay, sorry, I'm just seeing a new face. Okay, sorry. All right. So what's the rationale behind it? Why can we use the ultrasound to check for shock? And how does it help us? It's quite simple, all right? Number one, we want to check the heart, the pump, all right? We want to check how is it pumping. You know, is it pumping fine? Is something else causing the shock? Or is it not pumping fine? And is that the cause of the shock? Or is something stopping it from pumping? Is something obstructing it? All right. And that's why it can't pump properly. We want to look at the tank. All right. So the tank is basically your veins. That's where most of your blood sits. Sorry, not the pipe. So the tank is the veins. All right. So that's where all this fluid sits, the straw. All right. So we're looking at the IVC, we're looking at the pleural area, abdominal areas. Is the tank leaking? Is the tank empty? Does the tank need to be filled? All right. Or the straw, does it need to be filled? Is it empty? Is it leaking? That's what we're looking at. And eventually the pipes. So that's the aorta and the femoral vessels. Although we concentrate more on the aorta in terms of dissection and femoral vessels in terms of DVTs. All right, so that's what we're looking at. So are we also looking at, are our pipes leaking? or are our pipes obstructed? Because these are all the things that lead to shock. Okay, so let's have a look, and we're going to logic a lot of this out. Number two, if it sounds like I'm wavering, please just somebody give me a slap. Baby was up until 4:30 this morning with colic, so if I'm a bit under the weather, just let me know. All right, so it's a lot to think about when you really look at it, because shock is not a small topic. There's a whole international society dedicated to shock. They release new protocols every year. There's this and that. You should give vitamin C time. There's a whole lot of things that go to shock. But the truth is, at the end of the day, those are nice things to know about. But if you don't even know that it's shock, you can't start your treatments. All right. So let's be systematic and logical. That's how we're going to think about it. All right. So we're going to start with the easiest one, which is hypovolemic shock. So what is hypovolemic shock? Hypovolemic shock means that if you have a pump, which is your mouth, and you have the straw, the problem is that, number one, you don't have enough fluid in either of those. For whatever reason, you're bleeding internally, you're bleeding externally, you've lost it because you're breathing too hard, so insensible losses, you're sweating, you're vomiting, you've got diarrhea, whatever the case may be, but you just don't have enough fluid, all right? Now remember, your blood pressure, where do you measure your blood pressure? When you want to take somebody's blood pressure, where do you put that machine? You put it around their arm. And what are you checking over there? What vessel runs over there? Brachial artery. Agreed. So you're trying to check the amount of pressure that's actually running through the artery. So in other words, for you to have a normal blood pressure, your pump must be able to push. It must be able to push a sufficient amount of liquid, and you must be able to push that liquid through a straw that's of sufficient diameter and that also has sufficient liquid inside. So what's the problem with hypovolemic shock? Number one, let's go to the pump. Does the pump have enough liquid inside it? All right. So what's going to happen to that pump to compensate? What do you think it's going to do? Everybody's whispering. Come on, talk. Yeah, I'm going to pump harder and faster. Agreed. So it doesn't have enough inside it. So remember, we always talk about the heart. It needs to stretch to be able to contract. So it's not stretching as much. So we expect to see a heart that's not stretching as much. And when it is contracting, it's contracting very hard and very fast. So it's doing that. So we expect to see tachycardia, and we expect to see a heart that's working in overdrive. Okay, which kind of matches what you see clinically as well. You see a patient with tachycardia, and you see a patient with a very dynamic heartbeat and things like that. All right. And what do you expect to see in the vessels? Do you expect to see them full of fluid, or do you expect to see them empty? Empty. Can you check every vein in the body? So which is the most common one that we check on ultrasound? Okay, I'll give you a clue. It runs inferior, and it's known as a vena cava. So it's the inferior vena cava. Your students, okay. So what do you expect in the inferior vena cava? Now remember, we covered this a few weeks ago when we were talking about fluid assessment, right? So the vena cava, if you have a lot of fluid, it should just, or if you have sufficient amounts of fluid, every time you breathe in, it should contract a little bit, but not too much. Agreed. If you have too much of fluid, it shouldn't contract. But what happens if you have too little fluid? What should happen? It should be closing all the time, because whatever little fluid it has keeps on getting taken out. Agreed. So are these the things that we expect in hypovolemic shock, or am I just making it up? So what did we say we expect in hypovolemic shock? What do you expect the pump to be doing? Working over time. And what do you expect to be seeing in the tank, the veins? We expect them to be collapsing. All right. The pipes, what could be happening? Possibly. Because remember, we're talking about places where there could be loss of fluid. So in your aorta, can you lose blood via your aorta? Yes. If you have aneurysms and you have leaks, you could be bleeding into there. What if you have an injury to your liver or your spleen or a bowel and things like that? Can you lose fluid there? Yes, you can. Can you lose fluid in your pleural space? Yes, you can. What if you've got a hemothorax? So do you understand what I'm saying? So in other words, our ultrasound can try and take us in all those directions and tell us where we're actually losing our blood from, if we are losing blood. Okay, so let's have a look and see. Did we get it right or did we not get it right? Okay, so we expect to see a hyperdynamic heart. All right. So the hyperdynamic heart is normally best seen in the parasternal long view. So that's where you place the ultrasound in this configuration, right? So we've got the right ventricle, we've got the left ventricle, the left atrium, and we've got the aorta over here. So what do you notice about the left ventricle? Because that's what we're concentrating on. How's it working? Is it what we expected? It's working really hard, isn't it? It's pumping really fast. And what do you notice? If you compare it to the right ventricle, where every contraction, there's still a bit of space. Can you see any space over there with each contraction? No, because it's trying to push out whatever fluid it has. So it's the mouth doing, pushing as hard as possible. Morning, Nene. It's pushing as hard as possible, trying to get out as much as possible. All right. So if we think of the mouth and the straw, we've now got a straw that is collapsing all the time, and we've got a heart that's trying, and a pump that's trying to push really hard to keep that straw filled. Okay. And then what do we see on the IVC? So the IVC, we see the IVC collapsing every single time. Right? Every time this patient takes a breath, that IVC collapses. So once we start seeing these things, even if we don't know what's the cause of the shock, our mind starts going towards hypovolemic shock. And how do we treat hypovolemic shock? With fluids, isn't it? It's the easiest one because you just treat it with fluids in the hope that you'll build up the amount of pressure in the system. All right. Then we look at the tank. So we look around the liver. We could have free fluid that's around the liver. So that could tell us that we are bleeding if it's trauma. We could have ascites, we could have things like that. And we can look around the spleen as well, right? So, I mean, these are things that we've discussed before. That's why I'm not going into how we do it, because we should have an idea of how it's done, right? So that's what we should be seeing, okay? And then if we had a look suprapubic, for example, we may see fluid just above the bladder, okay? That would also tell us that we may be bleeding in the abdomen. It's maybe where we're losing it. And then we covered aortic dissections as well, right? So this is an aneurysm, right? Or dissecting aneurysm of the aorta with a flap and thrombus and things like that. So these are all the things that we can look for. Now, it doesn't mean every single patient have every single one of these signs, but hypovolemic shock should have an overactive heart with an IVC that's collapsing, right? So those are the two most common things that we should see, all right? So let's go to another one, cardiogenic shock. So what is cardiogenic shock? What causes cardiogenic shock? Okay, let's start with one, easy one, ischemia, all right? Myocardial infarctions may cause cardiogenic shock. What else may cause cardiogenic shock? Any idea? Heart failure, secondary to COPD, hypertensive heart disease, renal, all those things you learn in medicine, which is the reason why the ward rounds take 4 hours, isn't it? Because the consultant keeps on telling you the same list every day. Agreed? So let's logic it out. So what do you expect in cardiogenic shock is going to happen to the pump? In other words, the pump is not functioning properly in cardiogenic shock. So there's your mouth, your pump. There's your straw. Do you expect the problem to be with your straw? So where's the problem going to be? With the mouth. Agreed. So how's the mouth going to be working? Normally, abnormally. Abnormally. Is it going to be active, overactive, normally active, underactive? Underactive, very good. So we're going to see this heart that's pumping very slowly, that's struggling, that has a poor ejection fraction, which I'm hoping to show you guys next week, all right? What a poor ejection, how you work it out. It's actually very simple. We all look at echo reports and go, wow, ejection fraction. It takes literally 1 minute to work out ejection fraction, right? We may see direct damage to the heart, agreed. So in other words, if there's an ischemic part of the heart, it may not be contracting, it may be contracting incorrectly. There may be things like that that are happening, right? So we don't expect much to be happening in the tank. Do we expect much to be happening in the pipes? Not much, isn't it? Because there shouldn't be too much happening over there. So when we see a patient who has cardiogenic shock, these are the types of hearts that we see. All right, so here we have right ventricle, left atrium, aortic valve, and aorta. So what's the difference between this heart and the heart we saw the last time? It's hardly moving, agreed? It's just kind of sitting still. It's hardly pushing out anything, right? So whatever reason, for whatever reason, you may do an ECG, there may be a history of ischemia, whatever it may be. but there's something that's preventing this heart from pumping, right? So that's how we get to this point of saying cardiogenic shock. Now, when you have cardiogenic shock, you sometimes can see dilation of the IVC, all right? In other words, what happens is that this patient now, especially when they're in CCF, this is one of the things that will determine to us how we can treat this patient. If you have an ischemic patient who is fluid dependent, in other words, they're unable to pump out and they also have decreased levels of fluid, you can give them fluid. But what happens if you have a patient who's in CCF, has too much fluid already? It's no use giving them fluid, because what's going to happen? All that fluid's going to leak into the lungs, put them in pleural, pulmonary congestion. Okay, so the only other thing that you would look at is the IVC. So compare this IVC to the one that we saw the last time. It's barely moving. It's just kind of sitting over there because it's full of fluid. Agreed. So you can't treat this patient with fluids. What can you treat this patient with? You need something to make the heart beat harder and faster. And what do you use to make the heart beat harder and faster? Come on. We don't give them a kick in the heart. Don't do a 3-finger prostate exam. There's a drug that we give to make the heart pump faster. Yeah, everybody's listening. It's adrenaline. Okay. So in other words, this is an indication for inotropes. Okay. So these patients, especially if they are candidates for ICU, are the ones who need to be on inotropes. Okay, especially when they're in cardiogenic shock. The problem is, especially in our public institutions, there's so much that determines whether a patient goes into, yeah, Viagra, okay, that's a good one. You can, but Viagra more for pulmonary arterial hypertension. I think you read the label wrong when you bought it to it. Okay. But it can be used in certain circumstances. So anyway, we're working. So the problem in public institutions is that because we have a limited number of ICU beds, if you go to any Mediclinic, any life healthcare, if you have this, you're going to ICU, there's no doubt, right? In our case, we have patients, the determinants are age, the possibility of transplant, the possibility of long-term ICU, things like that. So there's a lot that goes into account before you start a patient on inotropes. So if you've got a 75-year-old, chronic kidney disease, known with COPD, CCF, pulmonary, in other words, and this patient presents like this, you're not going to immediately say put on inotropes, because inotropes need to be monitored, they need to be given safely, and there may not be a space in an ICU for a patient like this, So you've got to think of those things. So these are the types of patients that, yes, they should be on inotropes, but you will first consult with your physicians and say, listen, this is the history behind the patient. And they may tell you, no, it's fine, I've got place in ICU, start your inotropes and go ahead. And of course, it depends on which type of inotrope, but that was a whole other lecture that we discussed, right? So now I hope you guys are starting to get the hang of it. Let's try another one, all right? So septic or neurogenic shock. So what happens in septic shock? Any idea? Your body, sorry? Very good, vasodilation, eh? Yes, that's 100% right. So you get vasodilation, so your endothelial cells are no longer as close, so you get leakage of what you call intravascular fluid and things like that. So where is the problem? Is the problem with the pump or the pipes? It's with the pipes, isn't it? So in other words, you have this pump that's functioning properly, it's going. But now you have this very big straw that's sitting over there. So no matter how, if a straw gets big, the amount of pressure that goes through is always down. Agreed. So what are we expecting to see? What are we expecting our pump to do to try and compensate? Very good. So we're expecting our pump to start working harder. Right. Makes sense now. Agreed. So we're trying to overcome that by pumping harder. The tank, we already said, we expect it to be enlarged. All right. Poorly responsive, things like that. What happens in neurogenic shock? We spoke about septic shock, but what happens in neurogenic shock? Also vasodilation, all right, but why? So imagine you've got a patient with a C-spine injury. They have absolutely no connection between their midbrain and their vessels. So there's nothing to tell the vein, contract, dilate. So the normal response of a vein is dilate. I'm just going to get big. That's it, because there's nothing telling me to get small. There's no control over that soft tissue, over that, what you call it, smooth muscle. So that's why it just dilates. So that's why your patients often end up with low BP. So in other words, they're just pooling all of that blood. So he's 100% hypertension. They start getting edematous. There's a lot of other things to it, but in any case, this is not a discussion on shock. It's more of a discussion on ultrasounds, right? And what do you expect to be happening in the pipes? So in other words, let's say the femoral vessels, you'd expect them to be a bit dilated, but nothing much. Your aorta, you'd also expect it to be a bit dilated, but polycontract. There are a whole lot of things that go on. But the pipes are not the main thing. We're expecting the pump and the tank to be the main thing, right? So initially, what happens in early sepsis? So in other words, this patient is still doing well. The sepsis hasn't passed that far. You'd expect a hyperdynamic heart. Okay, you'd expect the heart to be pumping fast to try and compensate. But what happens later on? You get a polycontracting heart for a few reasons. Number one, you've got your inflammatory cascade that's going on, right? You've got anaerobic respiration that's taking place. You've got buildup of lactic acid. You've got septic emboli possibly. There's a whole lot of reasons why. Plus just sheer exertion. Your body's been working that hard for that long, right? Eventually the heart cannot cope. And in fact, if you start seeing bradycardia and you start seeing low BPs in a septic patient, you must know this has progressed quite far. We have a lot of our patients who delay coming to hospital. So some of them come and they are very septic right towards the end. And this is actually a poor prognostic sign, this one here. All right. Okay. So that's what we expect from the pump. All right. And then depending on what surprisingly, the IVC may be small to collapsing, all right? It may be, okay? And sometimes it may be normal, okay? The reason for that is actually the heart itself. Because remember, the IVC is actually dependent on the right ventricle for its collapsing and things like that, right? So you would rather look towards your peripheries. Okay, not necessarily with ultrasound, but clinically. So what do you expect to find clinically? Edema, that's for sure. Anything else? Especially in pediatrics, they talk about this. Mottling of the skin, slow capillary flow, poor urinary output, things like that, right? These are things that would lead you to, a diagnosis of septic shock. Okay. But this is what we'd expect to find on ultrasound. Okay. So we've got one more, hopefully. All right. Sorry, did I go backwards? My apologies. So we've got one more, obstructive shock. All right. So in other words, something stopping the heart from pumping. Okay. So these are normally pulmonary emboli or cardiac tamponade. All right. Cardiac tamponade can be due to a lot of reasons. Infective, TB, effusions, pericardial effusions, bacterial, viral, tumor. You can have trauma, direct bleeding, aneurysms, leak. There's a whole lot of reasons why you can get tamponade. And pulmonary embolism, normally secondary to any sort of coagulopathy, clotting disorders, DVTs, things like that, all right? So let's take, for example, a pulmonary embolism, all right? Let's start with that. What do you expect to happen in our pump? We discussed this just last week. Sorry? Yes, tachycardia, very good. Which side of the heart do we expect to enlarge? Right or left? Right hand side. Because remember, the right side is what pumps through the pulmonary circulation. Okay. So we discussed something called McConnell's sign, which is where you have a dilated heart with just a contracting apex because it hasn't had a chance to actually compensate. As compared to somebody who's, let's got COPD, where they've had a long time, you'd expect a hypertrophic heart, right? That's also enlarged and things like that. Yeah, whereas in tamponade, what do you expect in the pump? Sorry? Yeah, it's restricted, exactly. So you expect to see this. Sorry. Can you answer? All right. So you'd expect to see this effusion that's around. And you'd expect to see this heart that's unable to expand. So it follows Starling's law. It's unable to expand, so it's unable to contract. All right. So because it's unable to contract, then it follows this whole system of basically providing less blood to itself, and your patient slowly spirals downward until they die. Okay. So that's what we're expecting tamponade. What do you expect in the pipes, in the tank? Because now you've got this pump that's not able to push. So are you expecting your tanks to be dilated or contracted? contracted because they're not receiving as much blood as what they should, except for the IVC, because now you've got this backup of blood from the right ventricle that's going and plugging it up at the back. Right? So that's what you'd expect. And then in the pipes, particularly in the femoral vessels, what would you be looking for? Not only femoral, but let's say popliteal vessels. What would you use your ultrasound to check for? You'd look for DVTs. DVTs, all right. To see, listen, is this a pulmonary embolus or not? Okay. So that's what we'd be looking for. So, sorry. Oh, thank you, Toby. I thought you were going to say Viagra again. Okay, no, that's fine. Clots are fine, 100%. Okay. All right. So that's what we would expect to find. Okay. So this is what, now we're going to go through the apical view next week, hopefully, all right? But just to show you, this is the right ventricle, right atrium, left atrium. So what we expect to see is this very dilated right ventricle that's not really moving because it's pushing against this large amount of pressure. The only thing that can move is the apex because it can't really be stretched that much, right? And then you get a backlog into your right atrium and eventually a backlog into your IVC and things like that. And remember, there's less blood getting to the left ventricle, so it tends to become smaller, hyperdynamic, things like that. And this is a cardiac tamponade, right? So this is seen from the subxiphoid view, okay? So what do we notice? We've got the right ventricle, left atrium, right atrium. What's happening to that right ventricular wall? It's collapsing, all right, because there's so much of pressure on it, all right? So this is the type of tamponade that needs to be relieved urgently, okay? That's the type of patient where you would try and do an aspiration. If it's liquid, get it to theater. If the patients have trauma, you know, things like that. So these are the things that you look for in terms of cardiac tamponade, okay? All right. And then, yeah, this is also looking at McConnell's sign again. So we've had a look at this before. Right, so the dilated right ventricle that we can see, all right, McConnell's sign. And yeah, they're just showing it from the other side over there. And this is another view of a dilated right ventricle. This is the long axis view, all right? So we're seeing the left ventricle, left atrium, aorta, and right ventricle. Okay, so in other words, just showing you all the different ways that you can have a look and see, okay? Yeah, so that was just to show you what we would see in an obstructive one, okay? And then we'd see an enlarged IVC, like we said, all right, because of the backlog that's taking place in the right ventricle. And we may see DVT. So this is, remember, we're talking about the poor compressibility of the femoral vessels, okay? So in other words, you have this patient that comes in, you suspect shock. It's not to say that you must always diagnose it clinically. You have the opportunity to use your ultrasound. And especially you want to make sure that you can use your ultrasound so that you don't fluid overload your patient and you don't use your fluids for no reason. So for example, if you've got a patient in CCF cardiogenic shock, it's no use giving them a liter or two, you're not going to accomplish anything. And by the same token, if you have a patient in hypovolemic shock and you're giving them fluids, you can monitor their response. You can look at their heart, you can look at their IVC, look at their BPs, see it's improving. You've got a patient with neurogenic shock or septic shock, you know you've got to start antibiotics, you've got to start vasopressors. You can put them on liquids, there's no problem as well, it will help. But at the end of the day, you know in which direction you need to go. You've got a patient with a pulmonary embolus, it's no use tucking them full of fluids, you need to get them thrombolized, okay? So this is where it helps, okay? And these investigations don't take long. So in other words, you put your number one, you've got history, of course, that can let you know. But by putting an echo probe on, you get an idea of more or less what's going on immediately. I've got this hyperdynamic heart in a patient who's apyrexial and has been having diarrhea for the last 4 days. I've got hypovolemic shock. I'll look for the other things and try and move along from there. Okay. So that's basically what, sorry. Oh, okay. Okay, so those are the things that we are basically looking for. So there's one other type of shock that we didn't really cover over here, and that is anaphylactic shock, all right? And the reason why we don't cover anaphylactic shock is because anaphylactic shock is a different type of shock altogether. What happens? The patient takes something, immediately swells up, agreed. And then your patient collapses and your BPs go through the ground. And how do you treat anaphylactic shock? Any idea? Sorry? Yeah, adrenaline, exactly. All right. So you give them adrenaline. Sorry for a second, I thought you said centrifugal. I thought you meant like spin them around until the allergy thing comes out. You know, I was like, no, that's not enough. So your treatment of anaphylactic shock is adrenaline. IM straight into the thigh, 1M, right? Unless it's a child. But basically, that's your treatment. Okay, and then you give promethazine, hydrocortisone. You give the patient a repeat adrenaline if needed. But your ultrasound is of no use in that case. You can use it after that to see has your patient lost so much of fluid that they need fluid, things like that. But it doesn't really help. Okay, so that's the last one. And like I say, now the thing is we have a clearer diagnosis of what's going on. So it gives us, it helps us to direct our efforts in terms of management, right? Now, when I say that, still true, you have all the signs of pulmonary embolus, you will phone your physician, they will still not come, okay? We know that. Nene, you're looking at me and shaking your head because you agree, isn't it? You can tell them everything, they still won't come. But at least you know, you've documented all of it, you've got everything to show that, listen, I've tried my best. Okay? And at least you can, and when in saying that, there will be doctors who will respond to what you're saying and say, okay, listen, I understand what you're saying, so I'm coming. You obviously know what you're talking about, okay? So they will come and you have your, you do better for your patient. So are you an expert now at shock and ultrasound? No, right? There's still a lot of things that have to do with shock and ultrasound, but at least today you're 100% better at finding out whether your patient's in shock and what type they may have, right? Ultrasound in itself is a very complicated thing. It's like ECGs and all that. Just like I tell you guys, just as long as you can know the basics and you know how to navigate it, you don't have to know every single little nitty-gritty because you're not an ultrasonographer. At the end of the day, you work in an emergency department. You're trying to make sure that you know as much as you can to be able to get your patient going in the right place. So if you guys have been following these lectures from the start and you have these lessons being ingrained into you and you've been using the machine, you should be very proud. You really should be very, very proud. You are now on par with the first-year emergency med registrar. Somebody who's written their primaries, done ACLS, ATLS, PALS, MLS, all of that, right? Sorry, AMLS, neonatal, all of that. You're on par with them, all right? Except for 4 topics, which we're going to cover in the next month, all right? So that's what we're going to cover over the next few weeks, okay? Next week, we're going to cover more of the cardiac views. Then we're going to cover ectopic pregnancies. Then we're going to cover central venous access. And then we're going to cover TB abdomen, right? Those are going to be our last 4 topics in ultrasound for this year. The reason being, I realize a lot of people are struggling with x-rays as well. So it's no use knowing how to diagnose a cholecystitis or know how to use color flow Doppler to diagnose a urinary stone, but you don't know how to diagnose a pelvic fracture. So actually, we're going to finish up ultrasound in a month, and then we're going to go on to x-rays. We're going to cover x-rays in a systematic fashion like what we did for this, all right? And then once we finish that, we'll do blood gases, and then we'll come back to doing more ultrasound again, all right? But still, for the next 4 weeks, we'll still be covering ultrasound, but at least you guys get an idea of just those last 4 topics. The reason being, sometimes it's very difficult to see subxiphoid and long axis views, so we have to have the short axis and apical views, which I'll show you. And Malusi is going to model for us, hopefully today or tomorrow, so we'll put that on there. Ectopic pregnancy, because it's one of the common reasons of hypovolemic shock. TB abdomen, because it's one of the common diagnoses in South Africa, and mimic peritonitis, all right, in acute abdomen. And we need to know how to put in CVPs as well, all right? So that's what we're going to do. So do you guys have any questions or anything that you would like to know or anything that didn't make sense? Even the people on Zoom, welcome to ask. But I hope it made a bit of sense. The thing is, I know, listen, I was also a student at one stage. You listen to one lecture, it doesn't mean you're an expert. You retain about 10% of what you actually see today. So I'm not expecting you guys to go out and do all of that. But at least go over this again sometime. Take out the machine. You have a patient with low BPs. You have another weapon in your arsenal. Go and just play around and just go and use it and see what's going on, all right? At least within another month or 2, if you guys revise all the lessons, revise everything, you should at least be able to do an EFAST with relative confidence, okay? You should at least be able to check for shock and pulmonary embolism with relative confidence, be able to look at intravascular volume with relative confidence. I'm not saying you should be an expert, but at least you should know, okay, I should be going in this direction to actually, get to my diagnosis, okay? So, but in terms of today, any questions, anything that's still confusing, anything that needs to be explained a bit more? Are you guys okay? did I just speak too fast and everybody fell asleep? All right. In that case, I wish everybody the best for today. And on Friday, we'll be discussing nasal emergencies. Okay. All right. Thanks. Okay.